All right, Salim Razaya here, back again with another Walking the Line from Research to Practice. And this time we're going to be talking about the BOUGIE randomized clinical trial. So, this was an interesting concept or shift for a lot of us in terms of changing how we manage airway. And it was with the publication of this single center study in 2018 called the BEAM trial. And what they found in this trial is that when you use a BOUGIE first and then feed your endotracheal tube versus an endotracheal tube with a stylet, your first pass success with the BOUGIE was 95%. One of the highest numbers I've seen. Most EM studies are probably around the 85 to 90% range. So 95% is pretty high. The problem is it was a single center study, and standard operating procedure was everybody trained with a BOUGIE. So everybody knew how to use it. They had fidelity with it. So the question now becomes, if we apply this new technique to a bunch of people who haven't practiced with the BOUGIE, will we still have as high a first pass success rate? So the question they were trying to answer is, does the BOUGIE increase first pass endotracheal intubation success compared to endotracheal tube with stylet in critically ill patients? So this is what they did. 7 EDs and 8 ICUs, so multi-center study. They compared BOUGIE versus stylet, and they only used a standard geometry blade. So it's important to emphasize this. This is not hyperangulated blades, okay? Now, 75% of the intubations were done with video laryngoscopy, 25% were done with direct laryngoscopy, but they were all standard geometry blades. Now, I was looking up for intubation pictures, and I came across this picture, and I had to share it. So I hope everybody realizes, looking at this picture, this is not how you hold a laryngoscope, okay? If you're holding it like this, you're killing your patient. How to kill a patient with a laryngoscope. So please don't hold it this way, but I actually found this online and thought it was worth sharing. As far as outcomes, back to the BOUGIE trial, the primary outcome was successful first attempt intubation. The secondary outcome of importance was severe hypoxemia, which they defined as an oxygen saturation of less than 80%. Now, 1,100 patients got randomized, so a lot of patients, big study. And I already said 75% had video laryngoscopy, 25% were direct. And then the last thing is that 45% of patients were intubated for altered mental status. So it wasn't that they were having oxygenation or ventilation issues. They just weren't protecting their airways. And so the majority of people, that's what they were intubated for in this study. So here on the left is our primary and secondary outcome. And then if we used a BOUGIE first and fed the ET tube versus a stylet loaded endotracheal tube. And here's what they found. Basically, no difference between groups. Now, there was no statistical difference. What's interesting is that there was this slight little numeric trend toward more hypoxemia with the BOUGIE. So let's go through some of the strengths and weaknesses. So first of all, there was minimal exclusion criteria, and there was also very broad inclusion criteria. I like this as an ER physician because this is exactly what we see. This isn't a niche population or a very select group of just traumatic brain injury or DKA patients. This is all comers, all critical care patients. And that's exactly what we see in the emergency department. The next thing is that, again, you'll hear me say this over and over again as I review trials, is were the baseline characteristics of the patients similar? Were they intubated for similar reasons? Did they get the same type of medications, pre-oxygenation methods, all these sorts of things? And they were balanced between groups. Now, it's an unblinded study, and the reason I mention this is that I don't know how you would blind BOUGIE versus stylet, but maybe if somebody wasn't familiar with how to use a BOUGIE, maybe they would abandon that and go over to endotracheal tube with stylet. And so again, that fidelity in an unblinded study is really important because we all have this subconscious bias. First pass success for intubation is a surrogate outcome, although we know it's associated with worsened outcomes if you don't get first pass success. But again, it's not the same. We don't have those long-term outcomes because you got it on the first attempt or you didn't. Did the patients do worse? There may have been other things like anatomic or physiologic difficulties with the airway that are not accounted for. So what does this study tell us? Well, I think it's important that we really try and replicate research. That's why we do this. The BEAM trial, which was a single center study, BOUGIE was the standard operating procedure. And although they showed a first pass success rate of 95%, When you now extrapolate that to a bunch of people where they haven't had BOUGIE training or standard operating procedure with a BOUGIE, the BOUGIE isn't magic. It requires practice like any other procedure. You remember the first time you try to do a central line, you're probably not that great at it. It's kind of clunky. It's a lot of steps. What's all the equipment in the kit? It took practice and repetition. It's the same thing with the BOUGIE. If you just adopt this, it could be a very dangerous thing for our patients. So here's the bottom line. In experienced hands, the BOUGIE does seem to increase first attempt intubation success. In inexperienced hands, it does not do that. It does not increase that first attempt intubation success. It's not about the device. It's about the skill of the user with the device. Now, I still advocate for using BOUGIE first for intubation, but only after you've practiced with it, after you've gotten comfortable with it, only after you have fidelity with it. It's not something you should just pick up cold turkey because we may not be doing a service for our patients. And there you have it, walking the line from research to practice. Leave me your comments and questions, and until next time.